Hi everybody. Tonight's lecture is on nutrition. That is chapter 23 and chapter 24 in your textbook. The first thing I'm going to do is a little crash course on the anatomy and physiology of digestion, and then another little quick course on nutrition. It's nothing in depth, but just to give you a general idea. So the anatomy and physiology of digestion. Nutrients are ingested. That means we eat them. They're absorbed by the body for growth, maintenance, and repair. And then the waste products of nutrients are eliminated. Therefore, the process of ingestion, absorption, and elimination are the process of digestion. The process primarily takes place in the gastrointestinal system. However, the kidneys do help a bit with elimination of waste products. The GI system is a closed, hollow, tubular system that begins at the mouth and ends at the anus. A series of ducts connect the gallbladder, the liver, and the pancreas to the duodenum of the small intestine. The gallbladder, liver, and pancreas are considered the accessory organs, and they are also part of the GI system. The ducts of the accessory organs drain digestive juices and enzymes into the duodenum to facilitate digestion. Digestion can be either mechanical or it can be chemical. Mechanical digestion means motion. The motion of chewing by your mouth when you break down the food, and the motion of churning or mixing of food that it takes place in the stomach. And then the motion of peristalsis that propels the food through the digestive system. This is all mechanical digestion. Chemical digestion involves enzymes and acids that break down food. The name of the enzyme usually begins with the substance it's going to break down, followed by the suffix "ase". For example, lipase breaks down lipids. There are some exceptions to this. Some enzymes do not end in ase, such as pepsin, which digests protein. So first, the food is taken into the body through the mouth. That's the ingestion of food. And the mouth mechanically begins to break food down by chewing. The mouth also excretes some enzymes to begin to break down simple sugars or simple carbohydrates. Next, the food goes into the esophagus. In the esophagus, no digestion takes place. Food is propelled by peristalsis to the stomach. In the stomach, the food mechanically is mixed, or as we like to say, churned, and mixed with the gastric juices. Some enzymes are released to digest protein and fat. At this point, when the food is mixed and churned, it is called chyme, C-H-Y-M-E. The chyme is then propelled into the duodenum. The duodenum is the very first section of the small intestine, and the duodenum is a very busy place because the majority of digestion is going to take place in the duodenum. The ducts of the gallbladder, liver, and pancreas enter here and excrete their enzymes into the duodenum. And pretty much at this point, digestion is complete. The food then moves to the jejunum and then to the ileum. Some digestion takes place here, but the main function of the jejunum and the ileum is nutrient absorption. From the ileum of the small intestine, the chyme enters the large intestine. When the chyme enters the large intestine, it is totally liquid. The large intestine receives the waste from the small intestine and propels it along by peristalsis. As the chyme moves along, water and electrolytes are removed from the chyme. No digestion takes place in the large intestine. Digestion is complete. But the waste travels from the ascending colon through the transverse colon to the descending colon to the sigmoid colon. All the while electrolytes and water are being absorbed out of the chyme. Then it goes to the rectum and it is expelled through the anus. By the time the waste reaches the sigmoid colon, it is a formed mass that we know as feces. Nutrition, by definition, is the process by which the body uses food, water, and other substances to provide optimal functioning of the body systems. Nutrients are divided into two categories. They can be macronutrients or they can be micronutrients. Macronutrients are acquired in larger amounts on a daily basis, hence the word macro, meaning large. And micronutrients are needed in smaller amounts. Your macronutrients are your protein, carbohydrates, fats, water, and the major minerals: calcium, chloride, magnesium, potassium, phosphorus, and sodium. The micronutrients are your vitamins and the trace minerals. If you look at the macronutrients in the outline, proteins provide 4 calories per gram. Carbohydrates also provide 4 calories per gram, while fats contribute 9 calories per gram. So the amount of calories you get from fats is twice or more than twice what you get from a protein or a carbohydrate. Protein, carbohydrates, and fats are your energy nutrients. Those are the only nutrients that provide calories. Metabolism is the process that breaks down food molecules in order to provide energy to living beings. The body converts food into chemical substances that can be absorbed by the blood and used by the body. Proper nutrition is necessary for growth, healing, and body function. Good nutrition strengthens the immune system, which promotes health and helps prevent disease. Even a slight nutrient imbalance can lead to serious health problems. The energy nutrients. An energy nutrient is ingested, taken in by the body, digested, or processed by the body, and it provides energy or calories. The body requires energy in order to function properly. It's supplied to the body in the form of calories or kilocalories. That's why you'll see the K in front of the calorie. The number of kcals needed for the body to function optionally depends on your age, your gender, your activity level. If you look at page 444, you can see a list of that on table 23.1. And again, there are 3 and only 3 main nutrients that provide calories. Those are proteins, carbohydrates, and fats. First, we'll talk about carbohydrates. Carbohydrates, there is no recommended daily requirement except 45 to 65% of the total daily calorie intake should be complex carbs. And I'll explain that in a minute. Carbohydrates, the initials for that are CHO, are the main source of energy for the body. Carbohydrates are more quickly digested than proteins and fats. An excess of carbohydrates in the diet contributes to weight gain and obesity. Carbohydrates are sugars, and they are classified as simple carbohydrates or complex carbohydrates. Simple carbohydrates or simple sugars are glucose. You find that in berries, grapes, sweet corn. Fructose, which is fruit sugar. You can remember that by the F, fructose and fruit. Sucrose is table sugar. Lactose is milk sugar. Simple sugars are absorbed rapidly. The second group of carbohydrates are your complex carbohydrates. Complex carbohydrates contain a combination of several simple sugars. They take longer to digest and absorb so that the person's going to feel full longer. Complex carbohydrates include fruits, vegetables, starches, and fibers. They're healthier for you because you're going to feel full longer, and this keeps your blood glucose level more stable. Complex carbohydrate intake, Complex carbohydrates include whole fresh fruit, potatoes, broccoli, whole wheat bread, and pasta. If you look on page 449, you'll see a complete list. The second type of complex carbohydrate is fiber. Fiber is a carbohydrate, but the body cannot digest it. There's soluble fiber. Soluble fiber mixes with water and stays in your stomach a while, and it gives people the feeling of fullness. And soluble fiber acts like a bulk laxative. If you've ever heard of Metamucil, this is what Metamucil does. So it pulls water into the intestine to help prevent constipation and promote normal bodily function. Insoluble fiber acts like a bulk laxative, sort of like Metamucil. It pulls water into the intestine to help prevent constipation and promote normal bowel function. Americans as a group do not consume enough fiber, and fiber is extremely beneficial. First, it lowers our cholesterol, it promotes normal bowel function, it prevents constipation, it aids in mineral absorption, it helps to decrease the pH of the colon, which inhibits pathogens and cancer cell growth. It promotes the normal flora of the digestive tract, and it helps to promote weight loss. As nurses, we need to teach patients about the health benefits and food sources of fiber. It's very important, if you do decide to increase the fiber in your diet, that it be increased gradually over a 2 to 4 week period. If you increase your fiber intake too rapidly, the person is going to have severe flatulence, which is a fancy word meaning gas. Examples of fiber are oat and rice bran, beans, oatmeal, apples, oranges, apricots, strawberries, pears, blueberries, dried peas, celery, and carrots. There is a list on table 23.3, page 450. So that's your carbohydrates. You have simple carbohydrates, complex carbohydrates, and fiber. Glycogen, I just want to mention, because glycogen is the storage form of glucose. When you have enough glucose in your body, glycogen is stored and processed in the liver. When you need it for energy, the liver is going to convert it to glucose. So glycogen is the stored form of glucose. The next category are proteins. The normal daily requirement is 50 to 60 grams a day. Protein promotes tissue growth and repair, such as when you have a wound, you need protein to heal. Protein is made up of amino acids. There are 9 essential amino acids in your body. Amino acids contain nitrogen, which is needed to build new tissue. A complete protein contains all 9 of the essential amino acids. Examples of that are cheese, milk, eggs, fish, pork, beef, and poultry, and soy. Primarily complete proteins come from animal sources. Incomplete proteins do not contain all 9 essential amino acids and come from plant sources: corn, wheat, seeds, beans, brown rice, and nuts. But by eating 2 or more incomplete proteins, a person can still meet their protein requirements. So, for example, if I eat a peanut butter sandwich on whole wheat bread, between the 2 of those things, I have all of my 9 essential amino acids. So for proteins, remember that they're made up of amino acids. A complete protein has 9 or all of the essential amino acids, and a complete protein does not have all 9. The next group are fats. Another name for fats is lipids. The American Heart Association recommends no more than 25 to 35% of your daily calorie intake consists of fat. Fat provides energy when carbohydrates are unavailable, and it adds flavor to food. Some fats are produced by the body. That would be cholesterol. Other fats are obtained from food, like butter, egg yolks, and chicken skin. Dietary fats have a negative connotation to most of us, but a healthy diet really does need to include some fat. Some fats are better for you than others, so you need to know which fats cause elevated cholesterol, heart disease, and type 2 diabetes. The first group of fats is the monosaturated fats. These are fats that are liquid at room temperature and solid when refrigerated. That would be olive oil, canola oil, peanut oil. These fats are not necessarily bad for us, and they may be good for us because they help to lower your bad cholesterol, your LDH, which is your bad cholesterol. Polysaturated fats are corn oil, soybean oil, sesame oil, and sunflower oil. The polyunsaturated fats of omega-2 and omega-6 fatty acids are found in some fish, walnuts, and flaxseed. Omega-2 and omega-6 fatty acids are actually good for you. They decrease the risk for type 2 diabetes and heart disease. So monounsaturated fats and polysaturated fats are actually not bad for you, and in some ways they're good for you. Then we get into saturated fats. Saturated fats are solid at room temperature. Saturated fat comes from animal sources, and this needs to be limited because it elevates your bad cholesterol. That's your LDH, remember. HDL is your good cholesterol, LDH is your bad cholesterol. LDH contributes to heart disease and type 2 diabetes. It's found in meat, whole milk, and cheese. Some saturated fat is present in hydrogenated vegetable oil and cocoa butter, and that's found in packaged cookies, cakes, and pies. So they also are not good for you, and they raise your chances of having diabetes and heart disease. Trans fats, these are probably the worst fats of all. They lead to high cholesterol and heart disease, and these are also solid at room temperature. Trans fats have had an extra hydrogen molecule added to them, and we've added this commercially. Learned a process in the lab where this could be added because food manufacturers found out by adding that extra hydrogen, the food is going to stay fresh longer and it won't spoil. Trans fats are found in processed foods and fast foods. Many places, cities like San Francisco, have banned trans fats, and they are slowly being removed from processed foods. So trans fats are being eliminated as they should be because they're very unhealthy. So remember, there's 4 types of fats: monosaturated fats, which lower your LDH, polysaturated fats, which have omega-2 and omega-6, and those help with diabetes and heart disease. Saturated fats, which also are not, which now you're getting into the bad cholesterol, they raise your LDH. And then trans fats, which are the worst of fats because they have an extra hydrogen added. They're hydrogenated and they're being banned from the shelves. Water, speaking of which, I'm going to have a sip. We need water to sustain life. However, water is not considered an energy nutrient because it contains 0 calories and provides no energy. However, without water, for any extended period of time, a human being cannot sustain life. Water is needed to survive. Aside from oxygen, water is the most critical component necessary to keep us alive. Our body is made up more than 1/2 of water. So 1/2 of your body weight is water. At least 6 to 8 8-ounce glasses of water daily are recommended to maintain hydration. Of course, this varies depending on your activity level, your age, your size, your health status, and your environmental conditions. Minerals and vitamins. Minerals and vitamins are used by the body for numerous functions. Major minerals are required in greater amounts than trace minerals. Like water, vitamins and minerals are not energy nutrients. They contain 0 calories and provide no energy. Vitamins are crucial for conduction of nerve impulses, bone and collagen development, and blood clotting. That would be vitamin K with the blood clotting. A vitamin can be water soluble or it can be fat soluble. Water soluble vitamins dissolve in water and are dissolved directly into, water soluble vitamins dissolve in water and are absorbed directly into the bloodstream. Water soluble vitamins cannot be stored. They have to be consumed daily. Because they can't be stored, they cannot build up to toxic levels. Fat-soluble vitamins, on the other hand, dissolve only in fat and can be stored only in body fat. A vitamin can be water-soluble or fat-soluble. Water-soluble vitamins dissolve in water and absorb directly into the bloodstream. Water-soluble vitamins cannot be stored. They have to be consumed every day. Because they cannot be stored, they cannot build up to toxic levels. Fat-soluble vitamins dissolve only in fat and can be stored in body fat when ingested in large amounts. Because they can be stored, fat-soluble vitamins can become toxic if they're consumed in large doses over time. Actually, that's a condition known as hypervitaminosis. Water-soluble vitamins are the B vitamins, vitamin B1 through 12, and vitamin C. Fat-soluble vitamins are vitamin A, vitamin D, vitamin E, and vitamin K. The major minerals, calcium, sodium, potassium, magnesium, phosphorus, and chloride, we have to ingest 100 milligrams a day for optimum health. Trace minerals will not require 100 milligrams a day. That's why you only require a trace. You do not need to memorize all the functions and sources, deficiencies, and excesses of vitamins and minerals, because we will cover those in further lectures. However, if you see table 23.4, 23.5 on page 452 through 455, you will be able to read about them. For the next section of this lecture, I want to talk about the promotion of health by the United States government. And on the top of, underneath the heading, I've listed the websites. First of all, there's the FDA guidelines and food labels. The Food and Drug Administration develops standards for the minimum amount of nutrients needed to protect individuals from disease. These standard guidelines are known as dietary reference intakes, DRI, and contain dietary recommendations for gender, age, pregnancy and lactation, and activity levels. It is required by law that nutritional facts are found on the food labels of all processed foods. Each food label contains the amount of calories. There is an example that you can look at in your book. I meant to bring with me a food label, but I negligently left it on my dining room table. So please look at food labels. It should list the amount of calories, the serving size and number of servings per container, the vitamin and mineral content. They'll list the amount of vitamin D, calcium, iron, and vitamin K, and the recommended percentage of daily requirements. FDA guidelines and food labels. The Food and Drug Administration develops standards for the minimum amount of nutrients needed to protect individuals from disease. These standard guidelines are known as dietary reference intakes, or DRI, and contain dietary recommendations for gender, age, pregnancy and lactation, and activity level. It is required by law that nutrition facts are found on the food labels of all processed foods. Each food label contains the amount of calories, the serving size and number of servings per container, the vitamin and mineral content, the amount of vitamin D, calcium, iron, and vitamin K, and the percentage of daily recommended amount. These are required nutrients that Americans are often deficient in. Daily reference values, health claims, and labels for special needs. There is an example of a food label at figure 23.1. The dietary guidelines are revised and reviewed every 5 years. The newest edition is Dietary Guidelines 2015 to 2020. A new guideline should be coming out this year. The guidelines emphasize eating in moderation, eating only the amount of food required for a person's activity level, and choosing nutritious food, a variety of vegetables, grains, fat-free or low-fat dairy, and a variety of protein. Foods high in cholesterol, processed sugar, salt, fat, and alcohol should be limited. I also want to make a reference to the food pyramid in Choose My Plate and Healthy People 2030. The food pyramid was first introduced by the United States Department of Agriculture during the 90s and has been revised and revamped over the years. Choose My Plate was introduced by the Department of Agriculture to supplement and enhance the food pyramid. The food pyramid and Choose My Plate offer people healthy choices and can be individualized or customized to include factors such as your activity level, your weight. It helps people find a diet plan that fits their personal profile. The goal is to help a person make healthy daily food choices using a variety of nutrients in controlled portions that will realistically adapt to their lifestyle. Portion control is a very difficult thing for people to understand, but one portion is a small amount. A portion of food is about the size of your fist or the size of a deck of cards. The other website, Healthy People 2030, was first developed by the Department of Health and Human Services in the 90s. Every decade, Healthy People is reevaluated and revamped. The current program began in 2020, which is right now, and will be completed in 2030. During the current decade, the health will be promoted by stressing disease prevention and disability and eliminating discrepancies and improving the quality of life. We have various nutritional needs across our lifespans. The current eating pattern in the United States indicate that 3/4 of us, and I know I'm included in this 3/4, 3/4 of us do not eat enough vegetables, fruits, and oils. Although Americans do consume adequate protein, we don't eat enough seafood, legumes, nuts, and soy. Most Americans eat too much added sugar, saturated fat, and sodium. 2/3 of adults and 1/3 of children in the United States are overweight. Nutritional needs and eating patterns vary on physiological growth, activity level, and metabolism. Factors such as age, gender, periods of rapid growth, activity level, illness, injury, and pregnancy all contribute to the nutritional needs of each individual. So, the nutritional needs of the infant are greater than at any other time of your life. When think about it, your weight triples and the length doubles in the first year of life. During infancy, breast milk is preferred to formula because breast milk is going to help enhance the immune system. Toddlers and preschoolers grow more slowly than infants and have less energy demands. Although they are very active, they aren't growing as fast. Toddlers are fussy eaters, but their food choices improve when they're preschooler. So this is the time, parents, that lifelong healthy diet habits can be established with parental guidelines. Because when they go to school, your parental influence wane a bit, because children are influenced by advertising and by their peers. Think about how many TV commercials advertise horrible cereals for kids, but that's all they want to eat because they look so good and so cool on the TV. Adolescence is another time of rapid growth. During teenage years, the need for energy, vitamins, and minerals approaches the needs of the infant. Problem is that teens are even more strongly influenced by their peers, and food choices may be unhealthy, such as lots of fast food and pizza. Eating disorders become a concern during adolescence, especially among girls, but the incidence of eating disorders in boys is increasing. Nutritional needs also increase dramatically for the pregnant and lactating woman. Lactation means producing. Nutritional needs also increase dramatically for the pregnant woman and for the lactating woman, that is the woman who's producing breast milk. As a person ages from young adulthood to older adult, energy requirements decrease slightly year to year. Many factors affect the nutritional status of the elderly. First, there's medical conditions. People aren't hungry when they don't feel good. Many older adults have diabetes or hypertension that require them to follow special diets, which can be difficult, and it may not include their food preferences. Medication reactions. Your medication you're on can affect your appetite, can cause side effects like dry mouth, constipation, diarrhea, anorexia. So that's going to affect your eating patterns. Functional impairments affect your eating patterns, like poor dentation. Dentures or no teeth, for example, is going to obviously affect a person's ability to chew. And they may resort to eating only soft, overcooked food, which contains no fiber. Blindness and deafness can make it difficult to eat healthy. Deafness makes it difficult to understand food choices, and they may choose unwisely. You may say to an elderly person, "Would you like a bite of cake?" And the patient thinks you said, "Do I have a toothache?" There are only 4 taste buds on your tongue. That's sweet, salty, sour, and bitter. Without the sense of smell, other tastes are lost. So the reason you have so many different tastes is because you have those 4 taste buds, but also the aroma of the food adds to how the food tastes and enhances your sense of taste. So without the sense of smell, other taste buds are lost, or other taste is lost, except for sweet, salty, sour, and bitter. That's why many elderly people overload on foods that are sweet or salty. When my grandmother lived with me, you'd sit down to have dinner with her, and on her meat, she would put so much salt that it looked like a big white hunk of snow. But that's because that's all she could taste. Blindness affects a person's appetite. Imagine not being able to see what you're going to eat. It has a tremendous effect. So the sight of the food, smell of the food, and the reaction of your taste buds all work together. The other thing that affects the elderly are psychosocial problems such as dementia and memory loss. This patient or this person forgets how to use cooking appliances and forgets ingredients when they prepare food. Using my grandmother again for an example, she always loved to make beef stew, and over the years she started leaving out ingredients. So first she stopped putting in the potatoes, then she started leaving out the meat, and finally all that was in the stew were carrots. In fact, when you went over to see her in her refrigerator, from the top to the bottom, all that was in there were carrots. She just didn't remember how to make it anymore, even though she'd made it for probably 50 years. Depression, it could be a psychiatric depression or just depression you're in because of grief or some event in your life. It's going to affect your appetite. Some people don't eat when they're depressed, other people overeat. Your income. Many older adults are on a fixed income and the cost of food is rising. Carbohydrates are cheaper. Spaghetti and potatoes are a lot cheaper than meat, eggs, and milk. Not only is protein expensive, it's harder to chew, but you need protein for tissue growth and repair. I remember when I was in school and I didn't have any money, my diet consisted of a lot of ramen noodles and pasta. And so I definitely wasn't getting enough protein. The elderly adult requires less calories because they aren't as active and their metabolism has slowed down. Many elderly people suffer from dry mouth. Besides being a side effect of medication, dry mouth is a part of the aging process. You just produce less saliva as you age. You need saliva to help with chewing, swallowing, and it makes eating more enjoyable. Dysphagia, or not being able to swallow right, or difficulty swallowing is dysphagia. Pain, an oral infection, a toothache, painful ill-fitting dentures make chewing uncomfortable and the person doesn't want to eat. And then mobility problems interfere with the ability to cook and the ability to feed yourself. So all of those things affect the eating patterns of elderly people. Other things affect your nutrition as well, like gender. In general, males of all ages require slightly more calories than females. Your ethnicity and culture and religion can have a major impact on your diet and lifestyle. Cultural influence on nutrition are usually passed from generation to generation. Cultural values and beliefs and cultural laws affect your diet choices. Traditional foods are often associated with important life events, like in this country, a wedding cake, a turkey for Thanksgiving. These things help bond families and communities together within the culture. Food choices often reflect the foods of the region of origin. For example, in the Far East, rice is plentiful, fish on the coastal regions, and potatoes in Ireland. Certain religion may affect your food choices. Roman Catholics fast on Ash Wednesday and Good Friday. Some Catholic people still do not eat meat on Friday because that used to be a tradition. The Islamic religion prohibits pork and drinking alcohol. Seventh-day Adventists can have no stimulants. That would be coffee, tea, cola, no shellfish, no pork, or no alcohol. And in the Jewish faith, food must be prepared according to Jewish law. Separate pans and silverware are used to serve meat and dairy products. So as nurses, it's important to incorporate cultural and religious diet choices unless they interfere with the plan of care and it becomes detrimental to the health of the person. The nurse works in collaboration with the nutritionist to provide a realistic diet plan that adapts cultural food preferences to fit a diet that is acceptable to eat based on the person's medical concerns. Allowing the family to prepare meals may be a way to ensure that the patient maintain proper nutrition. As nurses, it's up to us to educate the family of any restrictions that are required because of the client's medical condition. Awareness of dietary preferences of different ethnic and religious groups and cultures is going to enhance your ability to provide culturally sensitive nursing care. And remember, just because a person is of a culture or religion, that does not necessarily mean that they're going to practice all of the nutritional requirements or beliefs of their culture. So you need to find that out when you do your diet history. The next thing that affects your nutrition is your lifestyle. Some people eat more when they're stressed out, especially more snack food. Other people skip meals when they're stressed out. Smoking can reduce your vitamin C level and can lead to lack of appetite. Alcohol adds calories to your diet. A 12-ounce beer is 150 calories, a cocktail 160. Alcohol also lowers the rate of your metabolism. A high alcohol consumption depresses the appetite and lowers your nutritional absorption and storage. Alcohol also depletes vitamin B and folic acid. Women that are using oral contraception may need vitamin B and C supplements. Some people overeat or undereat by choice. Other people may refuse to eat fruits and vegetables. Others may refuse to eat meat or dairy products. All of these lifestyle choices affect proper nutrition. I forgot to mention, but also weight loss diets can compromise healthy nutrition if they're extreme. For example, the Atkins diet that eliminated all carbohydrates and had the person eating large quantities of fats and proteins, that can affect your nutrition. Your personal preferences. Some people may elect not to eat fruit and vegetables. That's obviously going to compromise your nutrition. Others may decide to follow a vegetarian diet, eliminating red meat and poultry. Within the vegetarian practice, there's many levels. Vegetarians may allow themselves to eat fish, eggs, and dairy products, as well as plant-based foods. Or you could be a vegan and eat only plant-based foods. The extreme is the fruitarian. Fruitarians only eat fruits, nuts, honey, and vegetable oil. It is recommended that strict vegetarians consult a nutritionist, especially during periods of increased growth and energy needs, like pregnancy, breastfeeding, or recovery from illness. Vitamin and mineral supplements may be necessary to maintain adequate nutrition. Economics. We talked about this a little bit with the elderly, but it is more expensive to eat healthy. Fresh fruits and vegetables and lean meats will cost more than carbs and canned goods. People with little money and the elderly living on fixed incomes may opt for pasta and canned sauce rather than more nutritious foods just because they're cheaper. Shopping at Whole Foods and Trader Joe's is more pricey than buying your food at the dollar store. A balanced diet is affordable on a fixed income. However, if someone is living on a fixed income, education related to good nutrition is going to help them make better choices. You can refer people to community and government programs for assistance. There's WIC, that's Women, Infant, and Children. That will supply people with dairy products and formula to feed the baby. Food stamps, food banks, food pantries. There's a lot of resources out there to help people with nutrition. Health, illness, disease, surgery, and medication. Chronic diseases such as diabetes or maybe a gastrointestinal disorder are going to alter your nutritional intake, your digestion, your absorption, and your excretion. People suffering from these disorders are limited in their food choices based on what they can tolerate without worsening the symptoms of their illness. When a person is ill, for example, you've got a fever, you're nauseous, you're vomiting, you're in pain, all of these things decrease your appetite. However, nutritional needs and fluid requirements usually increase during illness. Medication can cause nausea, vomiting, and thus decrease one's appetite. Other meds directly affect your appetite. A lot of the psych meds make you eat more. Chemotherapy meds, probably you're going to eat less. After surgery, the appetite is decreased, and often the patient is an NPO, which means nothing by mouth. They will progress to a liquid diet, but all of this is going to affect your nutrition temporarily. Protein and caloric malnutrition occurs in patients with long-term insufficient calorie intake, resulting in weight loss. That will be accompanied by muscle and fat wasting. What here I'm talking about are people that are suffering from cancer, end-stage AIDS patients, people undergoing chemo or radiation. People with swallowing difficulties. If it's painful or difficult to swallow, your appetite's going to decrease. You're obviously not going to want to eat. You're going to want to avoid food. You know what that's like just when you've had a sore throat from a common cold or strep throat. You don't want to eat because it hurts to swallow. People with medical conditions that affect their appetite pose a unique challenge for the healthcare team. And then there's food safety. Foodborne pathogens are a serious health concern. Contamination with foodborne pathogens can lead to illness and even death. That would be salmonella and E. coli. Fruits and vegetables need to be washed thoroughly before they're eaten or used in food preparation. It's very important to cook chicken and ground beef thoroughly because undercooked chicken and ground beef are often contaminated. Don't leave food on your counter or table to cool before refrigerating because this gives time for the microorganisms to grow and multiply. Utensils need to be washed in hot soapy water, especially after meat or poultry preparation, to avoid cross-contamination with other foods. Your countertops need to be cleaned thoroughly with a solution of 1 part bleach and 9 parts water. to prevent cross-contamination with bacteria. 1 part bleach and 9 parts water will kill bacteria. I'm going to briefly talk about nutritional deficiency and excesses with your energy nutrients. That would be on page 483 and 488 if you want to read more in depth. An inadequate intake of nutrients can lead to health problems and less than optimal body functioning. An excess intake of nutrients can also lead to health problems and less than optimal functioning. So nutritional imbalances of minerals, vitamins, proteins, carbs, and fats, if severe, can lead to malnutrition or other medical conditions. Carbohydrate deficiency. There's really no known carbohydrate deficiency disease. If a person doesn't consume an adequate amount of glucose, the body will use stored fat for energy. This could cause a problem known as ketosis, and that can be a problem for type 1 diabetics. That's what happens with the Atkins diet. The person isn't using carbohydrates, so the stored fat will be turned into glucose for energy, and that's the theory behind how the person is going to lose weight. But if you check the urine of someone on this diet, they will be in ketosis and spill ketones into their urine. Carbohydrate excesses. Excesses of carbohydrate can cause weight gain and obesity. Carbohydrates increase your blood glucose levels. When your blood glucose level increases, so does your insulin production. When your insulin increases and gets rid of the carbs, then you have a low blood sugar. The low blood sugar is going to trigger your hunger, and you're going to eat even more carbs. This is going to create a vicious cycle, and the person's going to gain more and more and more weight. Protein deficiencies. Severe protein deficiency causes kwashiorkor disease. That's extreme malnutrition. It's seen in children from impoverished countries. The signs and symptoms start to show up when the babies are weaned. The signs and symptoms are emaciation, that's extreme thinness, wasting away of muscle, and a BMI of below 16. The child will have an edematous abdomen because fluid's going to collect in the abdomen. The liver enlarges, the child is lethargic, fails to grow, has multiple skin infection, and mental limitations are going to result if the condition is not treated early. Malnutrition is usually seen in places where there's extreme poverty. You will also see malnutrition in people with anorexia nervosa. Protein excess. Because protein will not, excess protein, a lot of people think if they eat a lot of protein, they're going to build great muscles. It will not be stored and used to build muscle. Excess protein is converted to fat and stored that way. So the protein is stored in fat. However, if a person has kidney disease, it can become worse with protein consumption because the kidneys cannot remove the nitrogen waste. People with kidney failure are on reduced protein diets. So are people with liver failure. Fat deficiencies. Fat deficiency is rare in this country. However, if you have a diet deficient in fat over a long period of time, you may become deficient in the fat-soluble vitamins, vitamin A, vitamin D, vitamin E, and vitamin K, because these vitamins are stored in body fat. Fat excess. Your fat intake should not exceed 25 to 30% of your daily caloric intake, according to the American Heart Association. Excess fat contributes to coronary artery disease, weight gain, and obesity. Remember, fat provides 2 times more calories per gram than carbohydrates and protein. So you take the same size piece of fat, piece of carbohydrate, and a piece of protein, eat that piece of fat, you're getting twice the calories you would be getting from protein and carbohydrates. Mineral and vitamin excesses and deficiencies will be discussed at a later date. Nursing and nutrition. When a person is in a facility, the nurse helps them with their diet in many ways. Some patients are on a special diet due to their medical condition, like high blood pressure, high cholesterol, diabetes. Others are on special diets following surgery or acute illness. At times, a medical problem interferes with the patient's ability to eat. At this point, we're going to explore the nurse's role in promoting good nutrition. Diet therapy and assisted feeding. The goal of diet therapy is to treat and manage disease, prevent complications, and restore or maintain health through the appropriate diet. Specific diets are ordered by the doctor, and the nurse performs a thorough nutritional assessment in order to help the patients meet their optimal nutritional goals. In your nutritional assessment, you want to do a diet history when the patient is admitted to help assess their nutritional and hydration status. A nutritional assessment is an ongoing dynamic assessment changing as the patient's health status changes. So you want to find out, how's the person's appetite? Has the person had any weight loss or weight gain? A significant weight loss or weight gain could indicate a disease. How many meals a day does the person eat? How many calories a day do they approximately consume? How much of their diet is carbohydrate, protein, and fat? What do they like to eat and what do they dislike? They're probably going to eat better if the food isn't something they hate. Like, I probably wouldn't enjoy my dinner as much if they served me liver. I'd much prefer a cheeseburger. Food, do you have any food allergies? A person allergic to peanuts or eggs, you'd want to make sure nothing containing those products was included in their diet. What are your cultural preferences? Do you have any digestive problems like swallowing? Any nausea, vomiting, diarrhea, anything like that? Are you on a special diet because of a disease? Do you have high blood pressure and you're on a low sodium diet? Are you diabetic and you're on a carb count? Are you on a restricted salt diet because you have high blood pressure? What time do you usually eat? Some people have 3 meals a day and they eat them at 8, 12, and 5, and other people have varied schedules. You want to get a full list of their medication. Find out if they're on any meds that cause appetite suppression or cause any side effects like nausea, diminished appetite, or altered taste. Does the person have any dental problems? Find out if they have any illnesses. What's their gender? Again, if it's a man, they're going to probably need a higher caloric intake than a woman. What's their age? The different ages, you may need a different caloric need. For example, infants need more, teens need more, pregnant and lactating women need more, the elderly need less. Your BMI, or your body mass index. BMI is roughly measured by using charts and formulas. There is a formula if you want to look it up. It's kind of complicated. Pretty much we use formulas. We don't use the formula, we just look at charts, which are convenient to find on your computer. The normal BMI for adults ranges from 18.5 to 24.9. It's based on the person's height and weight. The BMI is useful in identifying underweight and overweight individuals. Does the person need assistance with feeding? Are they independent? If they do need assistance, how much? Do they just need assistance with setups? Like maybe they need you to open their containers and unwrap their sandwiches and cut their food. Or maybe the person's totally dependent and they need to be fed. Then you do a physical assessment. You want to check the person's height and weight on admission. You need a baseline measurement that you can compare to ideal measurements and compare to any changes that happen during the stay in the facility. So you want to know the ideal measurements for height and weight by age, gender, activity level, and BMI. Do a skin check. An adequate intake of proteins, calories, fluids, etc. is needed to maintain skin integrity and prevent skin breakdown. Assess the skin for any breaks or redness. Skin turgor. Skin turgor, as you know, is the elasticity of your skin, and it provides data about your hydration status. You know how to check for tenting. Lift or pick up a fold of skin and let it go, and watch how quickly it returns to its normal position. Normally, the skin should return to its normal position immediately. Skin that takes 3 seconds or longer to return to its original position is a sign of dehydration, and as you know, that's called tenting. Keep in mind, skin turgor does decrease with age, so a little tenting is normal in an aging person. If you see edema, it could be a result of overhydration, so check for pitting. And lastly, lab values can give you a picture of a person's hydration status. For example, blood glucose levels can indicate high and low blood sugars. Maybe the person's hypoglycemic or not getting enough sugar and needs more for energy. You can do serum protein levels. And then hemoglobin can indicate iron and protein stores. You don't need to memorize any lab values at this point. Take a break at this time. When we come back, we're going to talk about special diets. To talk about special diets, there are many special diets a patient can be on. It could be a therapeutic diet because of their diagnosis, such as diabetes or no added salt if the person has high blood pressure. The diet may be ordered because the patient has had surgery and cannot eat a regular diet right away, or it could be ordered due to a chewing problem or a swallowing problem. It's the nurse's responsibility to check the physician's order to assure the patient receives the correct diet. First, we have hospital diets. If you look in the back of the outline, I put a copy of this. This is the progression of the hospital diet. First, I'll tell you that a regular general house diet or diet is tolerated all mean the same thing. Different facilities use different names, but they all mean unrestricted food choices. It's a balanced meal plan that supplies 2,000 calories per day. NPO. NPO means nothing by mouth, no food, no fluid. It's usually ordered prior to certain tests, preoperatively and postoperatively. The preoperative patient is usually NPO for 6 to 8 hours before the procedure. You want to make sure they were NPO to prevent vomiting while under anesthesia. Vomiting while under anesthesia can lead to aspiration and serious consequences. Always check with people. I remember a patient, I took him to the hospital. He had to have day surgery. Told him to be NPO after midnight. We get there at 5 in the morning. He tells me he's had nothing to eat. They hook him up to the IV. They told me I could sit with him because he was nervous. They could have him all ready to go in. The doctor comes in and he looks at the doctor and he says, well, I have to confess. I just have to confess to all of you. Last night at 2 o'clock in the morning, I woke up and I decided it'd be a long time before I could have anything to eat, so I better eat now. So I went downstairs and ate 2 packages of hot dogs. Thank God he said that, because if they had taken him into surgery, he probably would have aspirated, and the possibility of dying would have been pretty great. So it's really important to find out that the person has remained NPO before surgery. Post-operatively, the patient is NPO until their bowel sounds return. Again, you can't eat if you don't have bowel sounds. That's going to also lead to aspiration. If a person is NPO for an extended length of time, IV therapy and or parenteral nutrition may be ordered. A sign should be placed over the bed or on the door to alert visitors and staff when a person is NPO. The water pitcher should be removed from the bedside. I can't tell you how many times when you're in a new facility, a patient sees you from their room, calls you in and tells you they're very thirsty. Could you fill their water pitcher? You don't know they're NPO, and I've seen many times where people will fill the water pitcher. So make sure you check their diet order before you give them anything to drink, because they may just be trying to con you because you're the new person on the block. Clear liquid diet. A clear liquid is something you can see through, such as apple juice, water, ginger ale, and less carbonated juice drinks may be contradicted by the doctor or by the procedure, so check on that one. But you can see through them. Tea, coffee, water, plain Jell-O are all clear liquids. And there's a list on that sheet that I gave you. A full liquid diet are any liquids that are liquid at room temperature or that are going to melt at room temperature. That would be your ice cream. So, full liquids include all juices, milk, soup, gelatin, ice cream, custards, and cooked cereal. Again, it has to be a full liquid. The soup can't have big chunks of chicken in it. A patient that is newly post-op has an acute infection like nausea or vomit that causes nausea or vomiting is going to be on a clear liquid diet. The post-op patient won't be on a clear liquid diet until their bowels resume, until their bowel sounds return, I should have said. The patient will progress from a clear liquid diet to a full liquid diet to a soft diet to a regular diet. The final diet order will probably read diet as tolerated. That's because the patient may or may not tolerate a regular diet. So NPO, clear liquid, full liquid, soft, and then regular. A mechanical soft diet is a diet designed for patients who can't chew. They have problems with their jaw, they're missing teeth, they don't have any teeth, their dentures don't fit right, or for someone who is just too exhausted, weak, and fatigued to eat. The food has a soft texture, it's easy to chew, it doesn't take a lot of energy to eat it. This diet contains everything on a full liquid diet, plus additional soft foods like mashed potatoes, scrambled eggs, cottage cheese. The problem with this diet is it's low in fiber, so the patient is at a risk for constipation. And then a puree diet, that's food that you process in a blender or a food processor. The food is thicker than the food on a full liquid diet, but easier to swallow than a mechanically soft diet. So one thing to point out, if you were on a full liquid diet, you can have everything on the full liquid diet plus everything on the clear liquid diet. If you're on the mechanically soft diet, you can have everything on that diet, everything on the clear liquids, and everything on the full liquids. And the same thing with the regular. Regular diet includes everything. Then there's diets that are modified because of disease, because some people have diet modifications because of an illness. These diets are altered to either increase or restrict the intake of certain nutrients. A diabetic diet. The diet manages calorie and carbohydrate intake for the diabetic person. For example, it just might be a no added sugar diet, which means that the person can't add table sugar. It might be an 1,800 calorie a day diet, or most likely today is it's a carb exchange diet. There is a lot of material in your book about diabetic diet. If you would like, you should read about it. And we will talk about diabetic diet in depth when we get to Med-Surg. There's a sodium-restricted diet. That would be for somebody with high blood pressure, congestive heart failure, renal failure, liver failure. Typically, the sodium is restricted to 2,000 to 3,000 milligrams daily. I know that sounds like a lot, but read up and see how much we usually consume. Avoid added salt and check the salt content of processed foods. For example, canned goods, like if you look at a can of soup, it's very high in sodium. There's the fat-restricted diet. A renal diet. A renal diet is a very complicated diet which needs to be set up and maybe managed by a dietitian. It involves fluid restrictions, sodium restrictions, protein restrictions, and potassium restrictions, to name a few. A calorie-restricted diet would be a diet you would go on to lose weight. So, for example, if you usually consume 2,500 calories a day, maybe you'll go on an 1,800 calorie a day diet. And then there's the high calorie, high protein diet. People that have an increased need for greater nutrition are on high calorie, high protein diets. That would be somebody that needed to gain weight, somebody that was healing from a bad infection or an infected wound and needs promotion of growth and tissue repair. The general guidelines for assisting patients with their nutrition, if you look at Skill 24.1 on page 492, you want to check the doctor's order to make sure the diet being served is the correct diet for the patient. You don't want to give the diabetic patient the restricted sodium diet and so forth. Notify the kitchen immediately if the doctor changes the diet order. Educate the patient and assist him in ordering from the menu. Allow time for the patient to toilet, brush their teeth, or pray. Assure a pleasant atmosphere. So you want to eliminate unnecessary noise, eliminate odors. So what that means when it's mealtime in a facility like a nursing home, they will remove the linen carts and anything that might have an odor or a smell that is unpleasant. Make sure urinals and bedpans are cleaned and emptied. That should be anyway. There should be good lighting. If the patient goes to a room, a dining room, or a special room to eat, let them sit in the same place, in the same seat. A sense of familiarity makes eating more comfortable. Make sure if the person is eating that they're positioned for safety. If they're in bed, the bed should be elevated 60 to 90 degrees. Make sure the patient's comfortable. Nobody's hungry and wants to eat when they're uncomfortable. Educate the person about the purpose of their diet. Teach them what they can and cannot eat. Be aware of special considerations and educate the patient, staff, and family to the importance of following these considerations. For example, thicket, fluid restrictions, increased fluid, etc. If someone doesn't understand why you're adding thicket to their drink, they're not going to want to be compliant with drinking it because it doesn't taste good. But if they realize how serious it could be if they swallowed thin liquids, they're more apt to comply. It's important to serve and collect trays in a timely manner. You want to make sure that foods that are supposed to be hot are served hot and cold foods are served cold. Nothing more unpleasant than getting your meal tray 20 minutes after it was brought up from the kitchen and having your soup cold, your meat cold, and your coffee cold. I set up the trays. You want to make sure you help people open cartons, unwrap utensils, add sugar and milk to tea or coffee, buttering their bread or their vegetables, position and clean off the overhead table, and raise the head of the bed. I already said before a person eats, but I'll mention it again. Allow the patient to use the bathroom, wash their hands, brush their teeth, pray, whatever they need to do to make them comfortable before meals. You feed patients that can't eat independently. Make sure you hold foods and liquids if the patient is NPO. Record intake and output if the person is on intake and output. Record the percentage of the meal a patient's eaten. I have an example of that here in the back of my packet. If you want to look at that, I'll talk more about that in a few minutes. Be aware of the person's food allergies and make sure that their diet is free of these food and note and record any reactions or any new reactions to food that a person has. If something that they eat makes them have diarrhea, nausea, or vomiting, or they break out in a rash, for example. Now I'm going to show you my food plate and go over recording the amount of food they eat. I don't know if you can see my food plate. I tried to go to a store, to Walmart, and buy, you know, those things they sell for little kids in the grocery cart, and they have pieces of food, but I couldn't find it anywhere. So I had to create my own panorama. If you look at your chart, the meal intake record, it shows you a typical breakfast, lunch, and dinner. And then this meal plan is for a week, and I'd have every resident's name on it. So here is, the first one is Marcia Miller. And then for Sunday, I'm going to write everything Marcia Miller has for breakfast, lunch, and supper. In between you see N's. The N stands for nourishment. So if I didn't eat enough of my breakfast, you'd give me a nourishment, and so forth. And then it goes through for all the days of the week: Sunday, Monday, Tuesday, Wednesday, Thursday, Friday, and Saturday. Look at if you look, what you need to do after a person eats, you want to record the amount of food they ate, the percentage. But it doesn't just mean if they ate half of what is on their plate, it's 50%. You have to divide it according to the chart. So the one I've prepared so lovingly today is your lunch. And if you look at this, you'll see that the meat is 30%, and the dessert is 20%. So that's 50% right there. And everything else is the other 50%. So your starch is 15, your milk is 10, your bread is 15, your vegetables are 5, the margarine, they didn't even count. So here I have my meat, 30%. My dessert, 20. My vegetables are 5%. My bread is 15%. These aren't necessarily proportional. My milk is 10%, and my starch is 15%. So, if I eat all of my meat and all of my dessert, I've automatically eaten 50%, correct? Even though I didn't eat anything over there. I put my meat back. If I only drink my milk and eat my dessert, I've had 30%. Come on, dessert. So that would be 30%. I don't want to put you back in the wrong place. If I only don't like anything on this plate, and all I eat is my potato, my starch, and my vegetable, I've had 15 and 5, so I've had 20%. So you have to count it that way. Maybe I only eat, this is a huge portion of meat I'm serving. If I only eat half of my meat, I've had 15%. You don't have to try to gauge it particularly, but let's say I ate half of my meat, left the other half, that would be 15. Maybe I had not even a half a glass of milk. Milk's 10%. I didn't even eat half, so I'll say I did. I'll make that 5. My potato, I liked it. I ate the whole thing. 15%. My bread, I ate half a piece of bread, so you divide 15 by 2, which is impossible. So we'll say I ate 7%. I didn't even eat my vegetables, and I didn't eat all of my dessert. I only ate about that much. So 20% is the whole thing. Half of it would be 10%. I ate a little bit more, so I'd say I ate 15%. So I add that up, 5, 10, 15, 20, 7, carry the 2, 3. So I would have, with that diet that I showed you in the percentage, I had 57% of my meal. So hopefully that makes sense. I'm going to put my delicious lunch aside now and get back to what I was saying. Next, we're going to talk about feeding a patient. In hospital, patients almost always eat in their room. I don't know of any time when they don't. Maybe they go to the cafeteria with a family member. In nursing homes, some people eat in the dining room, some eat in their room, some, needing close observation and supervision, eat in a special room. So highly functioning clients who can feed themselves and have no swallowing difficulties usually go to the dining room. This allows for normalcy, socialization, and it's less stressful. A special room is set up that provides privacy and preserves the dignity of patients needing to be fed with dementia or having problems and needing more assistance. Again, when you're feeding a patient, allow them time to toilet, brush their teeth, or pray. Make sure the atmosphere is pleasant. Get rid of the odors, the noise, the lighting is good. Same place, same seat. Imagine if I have dementia and I'm used to sitting right here in this seat, and suddenly today you take me to a different room and you put me in a seat way over in the corner that I've never seen before. I'm going to be even more confused. So same seat, same place. Make sure I'm positioned safely so that my head is up 60 to 90 degrees, and make sure I'm comfortable. Serve appetizing foods tailored to the personal preferences. Again, don't give me liver for lunch. Encourage independence, even though sometimes it would be so much quicker if you could just feed the patient, because you want to get on with your work and you've got 100 other people that you've got to take care of. Try to be patient. Let them feed themselves. It's so important to encourage independence. Don't rush the person. Use a spoon. Always use a spoon. Don't use a fork. The fork has those tines in it that can hurt a person that has sensitive skin. Only fill the spoon 1/4 to 1/2 full. Make sure the person has swallowed the last spoonful before offering the next one. Don't keep shoveling them in spoonful after spoonful. Vary the food. Offer different foods. You don't want to just give me all of my meat and then all of my vegetable. Mix it up. Offer me drinks in between. Sit down with the person and make eye contact. This is safer because you can better see if they're swallowing their food or having any difficulty. It's more normalizing and equalizing too. And it creates a relaxed atmosphere. If I was feeding you and I'm standing up over you and you're shoveling it into my mouth, it would make me really uncomfortable and ill at ease. So sit down like you would sit down with a family member. Talk to the person even if they're nonverbal. They probably do understand some of what you're saying. Never call a clothes protector a bib. It looks like a bib. It's made of terry cloth like a bib, but you're putting it on an adult, so it's a clothes protector. Make sure you remove the clothes protector when the meal is done. Use thicket. This is thicket. I will talk more about that in a minute. Observe for signs and symptoms of swallowing difficulty or dysphagia. Record the percentage of the meal eaten. Again, refer to my chart that I seem to have lost. Here we go. Refer to the chart. And record the intake, or the amount of intake of liquids ingested. Now I'm going to talk about people that have to be fed or need assistance with feeding. First, I'm going to talk about dysphagia patients, then visually impaired, dementia patients, and then other problems. First of all, dysphagia. It means difficulty swallowing and chewing food. Patients that have dysphagia are at risk for aspiration. Aspiration means that the food's going to go into the trachea, which is your windpipe to your lungs, instead of into the esophagus, the swallowing pipe. This can block the airway and cause choking. The patient with dysphagia will always be on aspiration precautions. The signs and symptoms of dysphagia are a person that avoids chewy foods. Food often spills or drools from the mouth. They complain that food sticks in their throat. They cough a lot while they're eating. They spit and regurgitate. You may hear hoarse, gargly sounds while they're eating. I already said increased drooling. They complain about heartburn and pocketing. That's when things are pocketed in the cheeks or under the tongue. And they don't have a good appetite. Their appetite is decreased. It's diagnosed by a swallow study that's done in imaging. Swallow studies performed by a speech pathologist who feeds the patient a variety of food. The food is mixed with barium. So as the food is going down, the barium allows the speech pathologist to visualize how it's swallowed during an X-ray. There's a sign over the bed that says the patient is on aspiration precautions. Oral and pharyngeal suction equipment is at the bedside, so to suction the mouth and the throat. If the patient has a trach, always inflate the cuff before you feed them if they are fed. Raise the head of the bed to the highest position and make sure the person stays in this position for at least a half an hour after they eat. That's very important. Avoid sticky food, like bananas are sticky, and dry foods like crackers. You want to avoid watery, pureed foods because those are harder to swallow and they're easily aspirated. Semi-solid textured food is easier to swallow, like oatmeal, poached eggs, mashed potatoes, applesauce. Thin liquids like water, juice, tea, coffee, milk have the greatest danger of causing aspiration. Thicket is added to thin liquids to change the consistency to a semi-solid. It can either be nectar, honey, or pudding consistency. Sometimes this is done by the kitchen, but a lot of times it's done by the nurse. So we have our can of thicket right here, and this is, I measured it out, this is 4 ounces of water. So if I want this to be, there's 5 calories per serving in a can of thicket. Okay, so if I want this to be syrup consistency, I'm going to add, this is 1 scoop, they're saying. In the book, you can add 1 tablespoon. So I'm going to add 1 heaping scoop to this to make it syrupy consistency. That's not too bad. I'm going to mix it up. You can see it changes the color. Yuck. And then I'm going to drink it. It tastes all greeny. And I'm going to make it honey consistency. That's not thick enough. I'm still choking. So now I'm going to put 1.5 tablespoons in, which is 2 scoops according to my scooper. Now I've got honey consistency. I wish you were here so you could join me in a cup of thicket. Now it's really getting thick. The color's totally changed. It looks like gelatin. It tastes like water, but the consistency is weird. Then, for pudding consistency, you have to thicken 2 to 3 tablespoons. Or according to my scooper thing, it's 4 scooperfuls. So, mix it up real good. Now this looks nothing like water at all. It's going to taste nothing like water. And I certainly don't know how it's going to quench my thirst. But if I had to be on an aspiration regime, I guess I'd have to drink it. But it wouldn't be pleasant. I would be one of those people who would be having my family sneaking in thin liquids. But it's really important that you keep people on thicket, because without the thicket, they're probably going to aspirate. The water would go down into their trachea, and it could be life-threatening. The other patient I want to talk about is the visually impaired patient. This patient is able to feed themselves, and independence is encouraged. If they can't feed themselves, of course, we would feed them. We have special plates and utensils that make it possible for the patient to maintain independence. You have plates with high rims to prevent spills, things like that. The other thing is that finger foods, such as sandwiches, are easier to control, and the person can be more independent when eating them. When you bring somebody that can't see their plate, you just don't want to set the tray down in front of them and say, enjoy your lunch. You want to tell them what's on the plate and where it's located. So on my plate, I'm going to use the analogy of a clock. So this is 12 o'clock, and this is 6 o'clock, and everything in between. So at 12 o'clock, I've got my, what have I got? I've got myself a potato. At 3 o'clock, I've got my steak. At 6 o'clock, I've got my dessert, and then my vegetable. And then at 9 o'clock, I've got my bread. So can you see that? It's pretty clear. So this is the 12, the 6, the 3, and the 9. And that gives you an idea, if you can't see, of where things are located. You can visualize the plate in your head. Prepare, cut the meat, open the cartons, butter the bread, anything you can do to help them. Guide the person's hands to reinforce the location of the food. So when they have the spoon in their mouth, you can guide their hand to the meat. Show them with their hand where the potato is, the dessert, etc. If the patient has to be fed, always tell them before you give them a mouthful what you're feeding them. Offer choices. Let them decide what they want to eat next. Don't you be deciding for them. Don't rush. Again, you might have a million other things to do, but you want the mealtime to be relaxed and leisurely. Carry on a conversation. And remember, don't yell. They're blind. They're not deaf. Next kind of patient is your dementia patient. Dementia, you know, means a disturbance of your intellectual function. It could be a neurological problem. It is a neurological problem, but it could be caused by Alzheimer's from a stroke, many different things. So your attention and concentration are limited. You want to avoid distractions. If you have a neurological problem like dementia, too many distractions can be overwhelming. So you want a quiet, calm atmosphere that's going to eliminate distractions and allow the patient to concentrate. If possible, have the consistent same staff person help them. Somebody that has a really good rapport with the patient. This is going to promote consistency and helps alleviate agitation and anxiety. Be consistent with the time and place. Place the tray close to the patient. Remove the wrappers. Remove unneeded clutter, such as empty containers, salt and pepper they're not going to use, too many napkins. Clutter is going to cause confusion. Remove anything that isn't edible. Somebody with dementia, you may turn around and they're eating their napkin in their sugar packet. So you want to make it simple. Too many choices is going to lead to anxiety and agitation. Pour your liquid, such as it is, into a glass. This is going to look more familiar to the person than a carton. Finger foods are also something that the person can stay more independent eating and may be able to do it themselves. Guide their hands with the spoon to their mouth, like take their hand overhand with yours and guide the glass to their mouth. This helps them remember how to feed themselves. It encourages independence. Praise the patient, smile and talk to them. Stay with the patient during the entire meal. This helps redirect the patient and promotes concentration. Don't be impatient or try not to show impatience. If somebody spits or throws their food, it's not personal. It's just the frustration of their situation. Offer food the patient likes. Sometimes quantity is going to take priority over quality in this case. If the calorie intake is a problem, let's face it, eating 2 desserts or mashed potatoes swathed in butter is better than eating nothing at all if you're frail and underweight. And offer small, frequent meals. Again, I should say, There always I should have mentioned with the person with dysphagia, there should always be someone at all times with them when they're eating. Anybody in the nursing home, the dining room, and the special rooms always have personnel. They should have a nurse in the room that can perform the Heimlich maneuver should the person choke. So you should stay with these people at all times. When you're feeding people, treat them with dignity and respect. I guess the best way to put it is think of it as yourself or one of your loved ones that's in the nursing home and being fed. Intake and output, I'm not going to say too much about that because we've already covered that, but you should measure their intake and their output and make sure you record it. The average adult requires about 1,500 to 2,400 milliliters of fluid every 24 hours. Food allergies and intolerances are important to know. The most common food allergies are peanuts, wheat, dairy products, and eggs. A person with a food allergy experiences first skin rashes or hives. It can progress the more they eat of the substance to difficulty breathing and stomach problems. The symptoms get worse and worse each time the allergic food is ingested, and a severe allergic reaction can result in anaphylaxis. Anaphylaxis is a life-threatening emergency because the upper airway swells and the airway can be occluded so the patient cannot breathe. The food causing the allergy should always be avoided. Teach the patient and family about the foods to avoid and the signs and symptoms of anaphylaxis. A lot of children have peanut allergies. Some peanut allergies can be so severe that you can't even have peanut products at the same table or in the same house with the person. So it's important to let schools and field trip locations know if you have someone with an allergy. Food intolerance is not an allergic reaction, and it's not going to cause anaphylaxis. That would be like lactose intolerance and glucose intolerance. The symptoms of food intolerances are usually GI or gastrointestinal in nature. The person begins to feel bloated. They have a lot of flatulence or gas, diarrhea or nausea. The patient needs to modify his diet to limit or eliminate the food they can't tolerate. But again, if they did eat it, it isn't going to cause an anaphylactic reaction. It will cause them, though, to be very uncomfortable. Food and drugs often react with each other and interfere. Certain drugs and foods alter the effectiveness of each other. Some medications lead to GI discomfort and make the food taste unpleasant, so you don't want to eat. Cancer drugs, for example, make the taste of food very metallic. Antibiotics cause people to become nauseous and have diarrhea. Some medications cause your appetite to be stimulated. A lot of the antipsychotic medications they use in psych cause the person to get voraciously hungry, and they have a really big appetite. Others can suppress your appetite. Some nutrients alter the metabolism of medication. An example of that is dairy products interfere with how well you can absorb an antibiotic called tetracycline. Grapefruit juice interferes with a lot of medications. And medications can also interfere with the metabolism of nutrients. Sometimes food and drug interactions can create a toxicity with a nutrient. We'll learn more about that in Pharm and in Med-Surg. As nurses, though, it's important that we be aware of medication-food interactions. Luckily, pharmacy labels usually alert the user interactions, and your drug book is an excellent resource as well. Specific food-drug reactions are going to be discussed later in pharmacology and Med-Surg, so you do not need to learn them now. But if you look at table 24.2 on page 479, you can learn more. Enteral nutrition. I'm briefly going to mention enteral nutrition only because you're going to learn more about it in a future lecture. But I want to mention it because it is a form of nutrition. I want you to just be familiar with using enteral tubes to facilitate nutrition. Not that you need to know how to do one right now. Tube feedings can be used to replace oral intake or used to supplement oral ingestion. Enteral nutrition is used for patients with high nutritional needs, and this is important, but they must have an intact GI system. In other words, they need to have bowel sounds, and they need to be able to process the food in their digestive system. You'd use enteral nutrition for severe malnutrition, trauma, neurological disorders that impair swallowing. They put G tubes and J tubes and tube feedings in for people that have certain types of cancer, like throat cancer, when they're not going to be able to eat and get proper nutrition during their treatment. Then they'll have the tube feeding to supplement. First of all, you have what's called a nasogastric tube. If you look at figure 24, 6, and 7 on page 480, you'll see pictures. A nasogastric tube is a tube that's passed through your nose and it goes into your stomach. The second type of enteral nutrition is percutaneous endoscopic gastrostomy tubes. Those are what we call PEG tubes. That's a common name. So if somebody has a PEG tube, they have a percutaneous endoscopic gastrostomy. You can have a J tube, which goes into your jejunum. So it's a jejunostomy tube. So the tube is endoscopically inserted into the jejunum of the small intestine. Or you could have a G tube, which is a gastrostomy tube, that is endoscopically inserted into the stomach. These tubes can stay in place for a time, for quite a while, and the person can be fed through them when it is impossible to eat by the oral route. The feedings can be intermittent or continuous. The rate of flow is regulated by an infusion pump. In addition to the enteral feeding formula, a certain formula is made up that's put into the tube feeding. Medications can be crushed and liquefied and given through the enteral tube. Oh, so that is enteral feedings. Those are your PEG tubes and your nasogastric tube. Then there is something called parenteral nutrition. Parenteral nutrition is administered directly into your bloodstream through an IV catheter, which bypasses the GI system. Parenteral nutrition is used for patients that do not have a functioning GI tract. So maybe I'm post-op a major abdominal surgery. I'm not going to be able to tolerate eating for whatever reason for 12 days. Then they're going to insert parenteral nutrition through an IV catheter. There's partial parenteral nutrition, PPN. That's used for people who can meet some of their own nutritional needs, but they require supplemental nutrition. For example, I might be able to tolerate full liquids, but I'm not getting a total complement of all the protein, carbs, and fats that I should be getting. So they'll give me PPN so that it'll partially meet my needs so I won't become depleted over the short term. Then there's TPN, or total parenteral nutrition, that's used when people are so nutritionally depleted that they need long-term nutritional therapy and they cannot meet any of their own needs. Lastly, I want to talk about eating disorders, because we'll talk in depth about this during mental health. But the two that I want to mention are anorexia nervosa and bulimia nervosa. Anorexia means lack of appetite. The word itself is not a psychiatric disorder. It just means lack of appetite. And usually it's caused by something physical, like you're sick to your stomach, you're nauseous and vomiting. You just had surgery. But it can be a psychological disorder. Then it's always known as anorexia nervosa. The nervosa is the key word. Bulimia nervosa is the other eating disorder mentioned in this chapter. Eating disorders are characterized by extreme disturbances in eating habits that can severely affect the patient's health, and in extreme cases can lead to death. Anorexia nervosa results in excessive leanness and wasting of the body, known as emaciation, and eventually malnutrition. The patient is going to relentlessly engage in self-starvation. They're preoccupied with food. They play with their food. They look at their food. They mix it around, but ultimately they don't eat it. They have a distorted body image and see themselves as overweight, no matter how thin and emaciated they get. They never think that they're thin. If anorexia nervosa is not treated, it becomes very extreme. It will result in death due to damage to the body organs that's too severe to reverse. There are cases of that. Karen Carpenter, who was a singer, died of complications of anorexia nervosa because she didn't get really the right treatment or didn't follow the treatment. I guess you can take people to treatment, but they don't always follow it. Bulimic patient binge eats and then purges in an attempt to rid their body of calories. Purging includes self-induced vomiting. The person sticks a finger down their throat to make themselves vomit. Excessive use of diuretics. Those are medications that make you urinate. Excessive use of laxatives and excessive exercising. The bulimic patient, despite all this, is usually not underweight, but of average to slightly above average weight, because they consume so many calories. The bulimic patient may consume 50,000 calories a day when they're on a binge. Think about how much food that is. A normal average adult consumes about 2,000 to 2,050 calories a day. A bulimic patient can consume 50,000 calories a day while they're on a binge. So even that amount of purging is not going to make them thin. They still will have a lot of health complications. And like I said, I'm not going to go any further into that because we're going to talk about it in depth when we get to mental health. In conclusion, It's the nurse's responsibility to make sure the patient receives the correct diet, to educate the patient and family, and to ensure that the diet is healthy. Sometimes, though, we forget about ourselves, but we as nurses need to be healthy in order to provide and promote optimal patient care. In conclusion, it is the nurse's responsibility to make sure the patient receives the correct diet, to educate the patient and family, and to ensure the patient has a healthy diet. Sometimes we forget about ourselves, but we need to be healthy in order to provide optimal patient care. Forgive this cliche, but with nutrition, we should practice what we preach. That's it for tonight. I hope now you can go and eat a nutritious, healthy dinner, and I'll see you next week.